Okay, good morning everyone. My name is Dane Lynch and this is my research topic, the use of FET PET uptake dynamics for the spatial characterization of glioblastoma. I'd like to acknowledge my supervisors, Martin Ebert and Pejman Rowshanfarzad. So firstly, a little bit about glioblastoma. So glioblastoma is a highly aggressive brain cancer that becomes detrimental on the lives of those who are diagnosed due to its high mortality and devastating rapid degradation in brain function. Nearly 1,000 new cases are reported annually in Australian adults, with the median survival being as low as 7 to 9 months. It typically occurs in the frontal or temporal lobes of the brain, with diagnosis made using a combination of CT scans, MRI, and tissue biopsy. So on the right here we can see an example of a GBM tumour tissue on FLAIR MRI. Treatment involves surgery, quite aggressive surgery, and later radiochemotherapy and radiation therapy combined to remove any residual tumour. So the imaging modality that was focused on for this particular study was PET imaging, positron emission tomography. It is a functional imaging method that quantitatively measures biochemical processes through targeted radio traces that decay at a site of interest. On the right here we can see an example of a static PET image. Utilising quantitative imaging methods on GBM patient positron emission tomography scans can provide a deeper understanding on the extent of the disease progression while highlighting precisely how a patient is responding to treatment on a physiological level. Development of effectively targeted amino acid radiotracers in brain PET, such as F18 fluoroethyltyrosine or FET, has led to the rise of more comprehensive kinetic modelling of traces in dynamic PET imaging. As you see on the right here, this is a dynamic PET imaging which has been sped up over 20 minutes. This is the layout of the data set that was used for this research. As you can see here, there were 24 patients who had a dynamic and static FET PET scan following their tumour resection surgery. 9 of these patients went on to have a retest scan 5 to 9 days following. And then another 20 of these patients had an outcomes FET PET scan as well. This is the structure of the dynamic PET set, where each time frame had 55 slices of 128 by 128 rows and columns. Each PET frame was a minute apart, totaling to 20 frames over 20 minutes. So amounting to, for each scan, to be about 1,100 DICOM slices, amounting to 53 scans over the 24 patients, with some patients having up to 2 or 3 scans. A major limitation of this data set was the image delay in all scans from injection to the first frame acquisition, which was between about 40 seconds and 23 minutes. So there were 3 kinetic PET parameters which were evaluated within this data set. The first PET parameter which we calculated was the time to peak in units of minutes. The literature has shown that time to peak can non-invasively grade glioma. It has also been predictive of pseudo-progression of the disease following radiochemotherapy treatment, and it's also been proven to have prognostic value in patients, predicting progression-free survival. The second PET parameter was the influx constant, Ki, in units of per minute. The influx constant characterises the uptake rate of tracer flow from blood into brain tissue, and has been shown to be predictive in differentiating high-grade from low-grade glioblastoma cohorts, benign cohorts. The third parameter is the volume of distribution, VD. It has also been shown to be predictive in differentiating high-grade from benign cohorts. So typically we see an early time to peak and elevated uptake constant and volume of distribution to be conducive of glioblastoma tissue. This is an example of a study in 2018 by Volmanka, where 162 patients with newly diagnosed glioma were evaluated using dynamic FET PET. A combination of time to peak, late slope, and tumour to background ratio was used to differentiate between glioma WHO grades. Aggressive WHO grades 3 and 4 were dominated by a high proportion of voxels with an early time to peak, a negative late slope, and high tumour to background ratio. As you can see on the right here, the average high grade curve tended to follow this shape here with that negative late slope as I just described. The feature for best distinguishing between grades 2 and 3 was the time to peak, whereas differences between grades 2 and 4 were strongly significant for all parameters. And glioblastoma is WHO grade 4, being the most aggressive. So while the utility of various dynamic PET imaging features, such as time to peak, Ki, and VD, have been investigated, there has been no assessment of the repeatability of these measures, nor a breakdown of the parameters on a voxel level for time to peak. This research presents the opportunity to be one of the first known investigations into both spatially remapping these kinetic parameters and in testing their repeatability, filling this gap as shown by this literature review table on the right, where up here we have the types of PET imaging features and the clinical area for which they've been shown to be used and have utility. So there are 3 aims for this project. The first aim being to calculate the time to peak on a VOXEL WISE and tumour volume basis derived from time activity curves. The second aim was to develop a methodology for calculating tracer uptake and volume of distribution 3D parametric maps using PATLAC graphical analysis. The third aim was to evaluate the repeatability of these generated maps and imaging features. So firstly, the time to peak was calculated to be the time taken for this maximum standardized uptake signal to be reached, or concentration activity, as shown on the right here by this time activity curve features diagram. So across all the patients, the mean tumour time to peak for the whole tumour time to peak was found to be 23 minutes. And this is a specific example in patient 3 in their pre-radiochemotherapy scan. As you can see here, a time activity curve was extracted from the whole tumour, with standardized uptake value on the y-axis and time on the x, where the time to peak was calculated to be 15 minutes, which is much earlier than the cohort average, suggesting aggressive tissue. The time to peak was also remapped spatially, being calculated for each individual voxel, shown by this map here, where regions of dark grey correspond to early time to peak and regions of white correspond to late time to peak. As you can see, within the tumour region contoured in red here, we had a lot of early time to peak. The voxels within this region could then also be evaluated in a histogram. And as you can see here, the majority of voxels within this tumour region had an early shifted time to peak, suggesting the aggressive behaviour in the pre-radiochemotherapy scan. This is a comparison of all 3 whole tumour time activity curves for patient 3 in their pre-radiochemotherapy retest and post-radiochemotherapy scan. As you can see here, there is a decrease in time to peak between both of these pre-radiochemotherapy scans, where the time to peak shifts from 5 minutes to 14 minutes, and there's also a slight elevation in the standardized uptake value, as shown by this curve here, suggesting that in that week there is a increase in the presence of glioblastoma tissue. Following their radiochemotherapy, the time to peak shifted from 14 minutes to 32 minutes, and the standardized uptake value dropped greatly, as seen on this curve on the right, suggesting a lot of the glioblastoma tissue had been eradicated. This is comparing their voxel histograms, the time to peak tumour voxel histograms across the 3 scans, and again we see a similar trend where compared to the retest, there is a shift to an earlier time to peak, but following the radiochemotherapy, there's a shift to a later time to peak. So in order to estimate kinetic parameters such as Ki and VD the following is required. A dynamic PET dataset containing all the required concentration activities in kilobecquerels per milliliter. Secondly, an input function that characterizes the delivery and availability of the tracer into tissue. This is usually calculated by segmenting the sinus vessels within the brain, using this region to extract a time activity curve, which we then call our input function. Thirdly, a kinetic model which mathematically describes the dynamics of how the tracer is transported from the blood into tissue and between tissue compartments. So for this particular study, a simplified compartment model was adopted, shown here, where the red compartment is the blood compartment and this green compartment is the tissue compartment. So in order to solve for the flux between compartments and the volume of distribution, we had to extract the plasma concentration from the sinus vessels in 3D slicer, as you see here, and also the volume of interest concentration from either each individual voxel or whole volumes, as shown here. So once we calculated these two time activity curves, we could then apply a PAT-like graphical solution by forming a plot like this for each individual voxel or volume, where the y-axis is taken to be the ratio of voxel or tumour signal divided by the input function, and the x-axis is the integrated input function signal and divided by the input function. Once we plot each of these ratios for each PET frame, we can then use linear regression to solve for the gradient and the intercept, where according to this solution, the gradient gives us the net influx constant from blood into tissue in units of per minute, and the intercept is the volume of distribution or partition coefficient, which can be thought of as the ratio of tissue to blood concentration at equilibrium. Once this gradient and intercept was calculated for each individual voxel, it was then remapped spatially from where it was calculated, giving us two distinctive parametric maps, one for the gradient and one for the intercept. So this is an example of a net influx constant map for patient 3 across their 3 types of scans. So typically a high influx constant within these KI maps corresponded with tumorous regions of the brain, as you can see by the red high uptake regions here. The mean tumour influx constant was found to be 0.061 per minute across the entire patient cohort. And all these maps have been co-registered with the patient's MRI, FLAIR MRI image. So this is an example of a volume of distribution map found from the intercept. High volume of distribution was also found to correspond with the tumorous regions of the brain, where the mean tumour VD across all patients was found to be 0.88. These maps were found to have a lot higher contrast than the KI maps, as you can kind of see by the presence of noise in these images, as opposed to the volume distribution maps. So in order to evaluate the uncertainty of these parameter calculations, I calculated something known as the coefficient of determination for each individual voxel. As I explained before, we use linear regression to solve for these parameters, and therefore we can calculate how well that straight line fits to the points using this R squared coefficient, where the closer to 1, the better the fit, indicating whether the parameters have fit well or poorly. And then once I calculate that for each voxel, it is then remapped. And as we can see, regions of red where there's been a poor fit in parameter and a high uncertainty in that calculation. So typically the cranial cavity volume, shown by these red kind of oval outline on the outside of the maps, was consistently a region of low R squared, and therefore high uncertainty in parameter calculation. And this was due to the fact that there is typically cerebral fluid in these regions where there is not a stable time activity curve concentration, time activity curve. So this is a comparison of, I've isolated the tumour region to see the behaviour of each parameter within that particular region for patient 3. So here we look at, and this is comparing patient 3's scan before and after radiochemotherapy. So with time to peak, we can see again a shift of time to peak to a later time, shown by the increase in blue region here. Whereas the uptake constant and the volume of distribution tends to decrease as opposed to the increase in time to peak. And this is shown by, again, by the increase in blue regions here and here. So the behaviour of these parameters within the tumour volume could also be evaluated by measuring the mean of these of this region, the maximum of this region, and the tumour to background ratio, which is simply the tumour value divided by the background value, which was extracted from a background region contoured by a nuclear medicine specialist. So 9 patients had a retest scan 5 to 9 days following their initial scan, allowing for stability of this parameter behaviour to be investigated using Blond Altman analysis. Repeatability could be assessed on 2 levels. The first level being whole volume, using the tumour and background extracted mean, maximum, and tumour to background parameter values. And also on a VOXEL WISE level, assessing the stability of each individual voxel value within the generated maps by dividing the maps into healthy and tumorous regions. So this is an example of a whole volume repeatability measurement for the maximum volume of distribution within the tumour regions. So as you can see here, for each 9 patient, we have a test and a retest measurement. We can then plot the test against the retest in what is known as a line of equivalence plot, where we expect the data to follow an x equals y trend if the measurements are quite stable between test and retest. Once we use this, look at this equivalence plot, we can see that Blond Altman analysis is sufficient, and we can form a Blond Altman plot by plotting the log difference between the test and retest values and against their means, shown by the blue points here. We then calculate the mean bias of these points and the repeatability coefficients, which kind of bound the differences. Using these 2 calculated values, we can then form what is known as a level of agreement for this particular measurement, where we interpret the level of agreement to be the ratio of test to retest measurements for this particular example, volume of distribution maximum, to fall within these bounds with 95% frequency. So the ratios to fall within these 2 values. So this level of agreement was calculated for all parameter measurements, as you can see here, by influx constant mean, maximum, and the volume of distribution mean and maximum, and also the time to peak for both the tumour regions and the healthy regions. So if you look at the levels of agreement here, the influx constant had quite a wide level of agreement when compared to the volume of distribution, which had a lot narrower level of agreement, and same with the time to peak, suggesting that this parameter was nowhere near as stable as the other 3. This was also done for the tumour to background ratio for the Ki and Vd parameter calculations, where we can see a level of agreements here. Again, this means that we expect the retest to test ratio of these tumour to background ratios to fall within these bounds, 95% frequency. As you can see, the influx constant TBR was actually behaved a lot, had a much narrower level of agreement as compared to its mean and maximum, due to the fact that it was possibly normalised by the background. As reference, standardised uptake value repeatability in FET PET has been found to be between about 0.8 and 1.25. So while this level of agreement is more narrow than these tumour to background levels of agreement, it's by a marginal amount. So next, the VOXEL WISE repeatability for each measurement could also be evaluated by comparing each voxel value for either parameter in both the tumorous and healthy regions. The first step to doing this was contouring a combined tumour region, and also shown by the red on this diagram on the right, and also a green healthy region shown on the right there. This green region was calculated by taking the whole intracranial volume and subtracting a dilated combined tumour region. The next step was to register the retest maps to the test maps. So this is an example of an uptake map for patient 3. As you can see here, the retest is slightly skewed when compared to the test map. And so we need to register them in order to put them in the same physical space, so we're comparing the same voxels. So rigid registration was used for this in 3D Slicer, where we can then obtain a transformed retest map and then compare the maps in what is known as a subtraction volume. So these subtraction volumes were formed by subtracting the test from the retest to give us volumes that look like this, where regions of blue indicate that the parameter has decreased from test to retest, and regions of red suggest where the parameter has increased from test to retest. This is an example in patient 7 where we see quite a decrease in Ki from test to retest, as you can see obviously by this retest, which is nowhere near as hot as the test there. This is an example of a difference map for volume of distribution in the same patient, where we see an increase in signal from test to retest, shown kind of in these tumour region here and this cranial region there. The fourth step was to then extract the voxels which we're interested in, either the healthy regions or the tumour regions, depending on which mask we use. So this was the VOXEL WISE repeatability for the influx constant across all 9 patients, shown by this level of agreement here, where these level of agreement are not ratios but differences. So we expect the difference between retest and test to fall between these values here, where the healthier region was shown to have a lot narrower level of agreement as compared to the tumour region. So for reference, the mean tumour value was 0.061 per minute, and the mean background value was 0.04. This is the VOXEL WISE repeatability for volume of distribution. Again, we see the similar behaviour where the healthy volume of interest has a lot narrower level of agreement. Again, we expect the differences between test and retest to fall between these values with 95% frequency. To give you an idea what these numbers mean, the mean tumour value was 0.9 and the mean background value was 0.3. So some ideas for recommendations and future work. So future studies in this field of dynamic PET imaging should look to have imaging acquisition beginning from tracer injection, with all imaging acquisition settings and reconstruction methods identical across patients, as extensive filtering and resampling had to be applied to the data, to this data in the pre-processing stages. Registration of PET frames could be explored to account for the head movement between dynamic PET frames. The tumour extracted parameters in this study, particularly in the pre-radiochemotherapy scans, could be used in predictive outcome models for patients with glioblastoma, given the progression-free survival of all these patients are provided. Finally, the tumour volumes used in this research have a large variance between patients, with a standard deviation of 38 centimetres cubed. Investigation into the effect of the tumour volume size on the parameter repeatability could be an area of further research using these developed techniques and data. So in conclusion, the presented approach for calculating parametric maps of dynamic FET PET scans allowed for enhanced spatial characterisation of glioblastoma by highlighting regions of increased uptake and early time to peak, with dynamic image noise and lack of early image frames being a major source of uncertainty. This study presents the first known quantification of test-retest repeatability in these kinetic FET parameters for glioblastoma patients, with volume of distribution being vastly more stable than the influx rate constant on both a whole volume and VOXEL WISE basis. Calculating the level of agreement in these parameters allows for statistically significant variation in measurements to be differentiated from random fluctuations. I'd like to thank all these wonderful people for helping me out with my study. And thank you all for listening.
Perfect timing. Questions?
Very good talk.
Thanks.
I liked it, enjoyed
Cheers.
it, good presentation. I have a question on slide 21.
Mm-hmm.
Is it a big deal to go back? Otherwise,
Not at all, if I do this.
You might have mentioned it already and I might have missed it.
Yep.
But you had the region of interest for the tumors for all three parameters. And my question is, who drew the region of interest? So were
Yep.
they from the doctor, or did you pick a threshold? You know what I mean, for the three parameters?
Yeah.
To,
Yeah, so all of these tumour regions or these tumour contours were done by Rowshanfarzad, a nuclear medicine specialist at Charlie's.
Yeah.
And she, from what I believe, she created these contours using semi-automated segmentation by dividing the, using tumour to background ratio and using segmentation to kind of create these regions. And she had to, I think, it's semi-automated because she had to manually remove some regions that only kind of a specialist can recognise that aren't part of the tumour region. But yeah, so it was not done by me, no.
Okay. And if I
But it was
may
only the one observer.
Good.
So ideally you would have a, if this study was done again, you would have maybe 2 observers create kind of 2 versions of the tumours to kind of account for the fact of observer bias.
And can I ask question B?
Yep.
If I could?
Yeah, that's all right.
Did you ever notice when you applied all the parameters, the TTP, kinetic index, and one distribution, that they actually exceeded the predicted region of interest, or were they sometimes based on?
So what you're asking, was their uptake kind of outside this tumour region?
Based
Yes.
on your parameters.
Yeah, there was. Yeah.
Thanks, Dan.
Yeah, no worries. Yeah, because these, I mean, regions are purely based off the raw static. All these contours were done on, static PET images. And so, yeah, there's definitely going to be uptake, which might not be within that region that was contoured.
Any other questions?
Yeah, I have a question. Really nice talk.
Thanks.
So how do you envision that these techniques could be used in the clinic?
Yep.
So would you being a physician be looking at the parametric maps, or would you be deriving quantitative parameters and comparing those to thresholds for grading the
Yeah. So there's a lot of clinical areas which this could be possibly used for. Glioma grading is a big one, pushing towards non-invasively grading cancer as opposed to having to always perform surgery, which is quite invasive on the patient. Ideally though, we're pushing towards having a kind of a model that describes the best way to treat these patients. And so if you can take a scan following this surgery and then look at all the features that are extracted from this scan, we can then form a model that kind of best describes how to treat the patient. And so these parameters here could be possibly quite useful, but obviously studies need to be shown that they are predictive of patients' outcome and progression and pseudo-progression, these other things. But that's the goal, is to have this personalised radiotherapy model, which possibly maps like this could be used for. Yeah. Hope that answered the question.
Yes, so why might you expect the kinetic parameters to be different between the normal tissue and the tumor?
Yeah. So why there might be increased uptake as opposed to
more rapid in the tumor time to peak?
Yeah. So the influx constant is describes how quickly, well, it describes the rate of tracer flux between the blood and the tissue, and this relates to the metabolism of the rate that the amino acid is metabolized in the brain. And so these aggressive tumour cells have been shown to have elevated metabolisms for amino acids. And that's why you would expect an increased Ki to be shown.
That's great. So, any questions from Zoom?
Yeah, I've got a question if that's all right.
Yeah.
So, how labour intensive is the process that you're doing at the moment, and at what gaps do you think there would be until such a quantitative technique could be used sort of in clinic?
Yeah, so it's a good question. So the most labour intensive part is definitely contouring the sinus vessels of the dynamic PET scans, which I had to do manually for all 53 scans. And that, again, will introduce observer bias, but there might be adaptive ways to segment these sinus vessels, possibly using machine learning or more automated methods than just me sitting there and contouring exactly where they are. So while that's the most intensive part, I could definitely see for ways that could be automated in the future. What was the second part of the question?
So what steps would need to be taken until this could be sort of a clinically used tool?
So I think standardizing a way to make consistent sinus vessel segmentations would definitely be an important step as a way of standardizing that across clinics and hospitals. That would be the major step, I would think.
Yeah, great. I really enjoyed the presentation. Very well explained. Thanks.
Thank you. Cheers.
Thanks, everyone.
Thank you.
Thanks. Kat, do you have any questions?
Just a really quick question. It's just above that. I can't see the slide numbers from here, sorry, but with your green brains. In terms of the cerebral fluid,
Yep.
the influence of that on your uncertainties, do you get a measure for how much that varies?
How much the cerebral fluid,
The influence on the uncertainties.
the influence of the uncertainties, right. So
Yeah.
this was kind of a way that I could visually show regions of low parameter uncertainty. In particular, I wanted to see whether the tumour regions which we're most interested in are not very certain, which for the most part it was. And as you can see here, for this particular patient, this is actually the tumour region in patient 3's retest, where there is some regions of high uncertainty, and this is possibly due to the fact that this patient had a very large resection, and that region there is actually been filled in with cerebral fluid. So, but in terms of like relating that exactly to how much it changes the parameter values, I have not calculated that, no.
Yeah, that's all right. That's all right. Cool.
Yep.
Thanks. Good answer.
Yeah. Thanks
Sweet.
very much, Kat. Thanks, Dan.